Today, I want to present the quiz-guided PBM intervention on AI mental health platform for stroke rehabilitation. First, I briefly introduce the concept of the very basic, the perfusion and frequency, and then I will explain the concept of the frequency in the pulsed PBM. And then there are a lot of clinical study for the stroke rehabilitation. I will briefly review. And then I will explain our cases, very exciting cases in the stroke rehabilitation. The first, very basic, already maybe many people here already know in this one. And the perfusion and frequency, it is very well known chart of the EEG frequency and perfusion chart. You can see in the delta frequency, there are a lot of perfusion usually relate to the metabolism during the sleep. Sleep require many blood flow. And the theta and alpha, we can see very deep here, the very small blood perfusion in the theta and alpha frequency. And beta 3, 20 to 30 in our cases, is the very high blood perfusion in the stressful situation. And between the alpha theta and beta 3, there are beta 1 or beta 2 activity frequency. In this beta 1 and beta 2, the blood perfusion is not so much and not so small. So that's why we call this beta 1. Sometimes beta 2 is the optimum perfusion. This is the blood frequency of EEG frequency and blood perfusion chart. It is important concept. We understand EEG frequency. And this is the one-page simple CAT analogy of explaining the EEG frequency and mental status. This is the cat in the rest in the alpha frequency. When cat drowsy, the frequency is theta and eventually delta. And in another direction, cat find the mouse that very slowly breathing and no motion. That's the sensory motor calm and calm focus. The beta 1 start. When cat catch a mouse, the beta 2 start in the active task. And when cat miss the mouse, cat is very stressful situation, then the beta 3 is generated. This is the beta activity. And another direction is the delta theta activity. This is the underarousal and overarousal. The delta theta alpha activity, the blood perfusion is very slow. The beta 1 is the optimum perfusion, and beta 3 is the highest perfusion. And in the delta, during the sleep, another lot of perfusion. That's the EEG frequency and mental status in a very short way. I want to explain the alpha peak frequency. It shows the generation mechanism of the EEG rhythm. As you know, the alpha frequency is made by the thalamo-corticothalamic oscillation, pace made by thalamus oscillation. The big alpha amplitude is coming from this kind of pacemaker activity of the thalamus. So many neural oscillator synchronized fired by a thalamus pacemaking make this kind of alpha rhythm, very big synchronous rhythm. Actually, all the EEG rhythm made by the synchronous activity of the neuronal assembly. That's what that kind of mechanism make a very big rhythm. So basic mechanism of the oscillation is synchrony of the lot of neural assembly. In this alpha case, the thalamo-corticothalamic loop made by the pacemaker making an alpha rhythm. And in the same way, in the photobiomodulation, some area under the peak stimulation fired by the external frequency stimulation make another, that kind of external rise stimulation make another synchronous oscillation. In that case, pacemaker is the external right stimulation. So under the shine area, right shining area, the neural assembly firing together using the pacemaker of the external right stimulation make the synchronous rhythm of that stimulation frequency. That's the entrainment. Using that kind of EEG generation mechanism, we can make the specific frequency rhythm in the stimulation area. This alpha rhythm has this kind of age developmental equation in the normative database. In our stroke population data in the acute phase stroke, we can see in the left hemisphere stroke, we can see this is the stroke population, normative population. You can clearly see in the left hemisphere stroke, the delta activity in the left hemisphere is increased significantly in the acute phase, and the right hemisphere stroke, we can see this is the stroke population and the normative population, and this is the difference between the normative database and the right hemisphere stroke population. We can clearly see the right hemisphere stroke delta activity is increased, and this is the significance. So we can see in the stroke acute phase, the delta activity increased in the lesion area. This is the basic concept in the stroke EEG oscillation in the stroke lesion area. The important thing is we can tune the frequency in specific lesion area using the pulsed PBM frequency. The basic idea of the PBM, this is the mechanism of action of the PBM in this chain relation is basically made by the mitochondrial activation. The mitochondrial activation make ATP and control of the reactive oxygen species, and also releasing the nitric oxide. Nitric oxide make a blood flow actually. And this metabolism make this kinds of transcription factor activation, make antisynapsis, make a synaptogenesis and neurogenesis, like here. And this is a one chain reaction in terms of the metabolism. Metabolism in the EEG, we can see the metabolism effect in the EEG amplitude. Some people having the very, very bad metabolism, in that case, EEG amplitude is very small. And in another direction, we have another mechanism of the activation of ion channel. This activation, right-gated ion channel, make, I already explained the EEG generation mechanism. The right-gated ion channel firing the specific neuronal assembly under the shining area with specific pulse, specific stimulation frequency. So under the right stimulation area, the neural assembly in all the ion channel is pulsed by the same stimulation frequency. The pulse right is a kind of pacemaker that many kind of neural assembly under the stimulation area make synchronous firing to make a same frequency rhythm. This is the right-gated ion channel kind of entrainment mechanism through this ion channel. So this ion channel make EEG frequency changes, tuning of the EEG frequency in specific frequency. And this make the EEG oscillation changes. Usually EEG frequency is the result of the neurotransmitter imbalance. Once the neurotransmitter imbalanced, for some people having the dopamine problem, the theta excess we can see, and serotonin problem, alpha excess, we can see the norepinephrine problem. Alpha is too slow, for example, GABA deficiency problem, then EEG oscillation is very fast. So this is the this EEG frequency is the reflection of the neurotransmitter imbalance. Then we can use the specific physical frequency stimulation, make that kind of oscillation changes. We can help the neurotransmitter imbalance eventually. So these two, basically metabolism, this is the EEG oscillation frequency, EEG amplitude, and EEG frequency we can change using the photobiomodulation. Actually, this molecular mechanism make a systematic change of the lymphatic drainage too. Lymphatic drainage is another mechanism of the brain neuroimmune function. The microglia is activated using the photobiomodulation, eventually making the neuroimmune function better. And that's another important mechanism. So metabolism and oscillation frequency changes and neuroimmune function increase. Usually other neuromodulations such as the current stimulation and magnetic stimulation can use this kind of ion channel mechanism, but they cannot have this kind of metabolism or immune function mechanism. That's the specialty of the photobiomodulation. And we can also see the neurogenesis, anti-neuroinflammatory, anti-apoptosis, anti-neurotoxicity, and also increase of the blood flow. That's the permanently you can have the pathology changes. And another important thing in our photobiomodulation, this is the same figure, but I want to emphasize the right-gated ion channel is active in these wavelengths, and mitochondrial activation is very important, very useful in these wavelengths. So we can use these two. We can take the advantage. We want to take advantage of both mechanisms. That's why we use the 8.15 nanometer in our photobiomodulation. And this is the basic mechanism of entrainment when we use if people having the F0 frequency, then we want to accelerate, then we can use the increased frequency to make accelerating. Sometimes we can decelerating like this. That's the true. The entrainment or a synchronization of external stimuli, or sometimes we can call this tuning the EEG rhythm. It is quite true in the transcranial current stimulation and photobiomodulation and the magnetic stimulation. In the current stimulation, that's the basic methodology in the current stimulation, but it is same for the photobiomodulation, and also I think the magnetic stimulation is the same idea. The basic idea of the QEEG guided neuromodulation is first we need to record EEG and pre-processing and finding the QEEG feature, and then normative comparison. Then we can find the abnormal area in terms of frequency oscillation amplitude and the location. So once we find the frequency once we find the location and abnormality of the frequency in this, then once we find the frequency and location, and then we can use that location and TH in terms of THS using the frequency, and we can accelerate or decelerate using the frequency. That's the basic methodology in current stimulation. We use the same idea. This is the case of the quiz-guided personalized TACS in Parkinson patient. In the past EEG pattern, they usually use the theta current stimulation. The slower EEG pattern, they use the beta current stimulation. They can see the theta current stimulation, they can see the beta reduction, and beta current stimulation, they can show the slow wave increase, but not significant in this case. But actually, the idea is the same. Theta is reduced here. For the theta stimulation, the beta is reduced. The beta stimulation, theta is reduced, but not significant in this case. But basically, their cognition and motor performance is improved in the Parkinson patient. This is the quiz-guided current stimulation methodology. It is very useful for understanding the basic methodology. Then I explained this concept in the current stimulation. And this is very well known, the RTMS study. This is the replicate study for the, usually RTMS only use the 10 Hz frequency. In this case, the depression improvement is very substantially improved. Only the population having the frequency just below the 10 Hz. So that means the too far from the 10 Hz, the population showing the very little change of the depression index. But just below the 10 Hz is very largely decreased the depression scale. That means the frequency tuning is more easier when we choose the very similar frequency when we apply the neuromodulation. That means, for example, you can see these two oscillator is starting frequency is different, but as time goes, these two frequency finally make a same oscillation like this. The first, the frequency is different, a little bit difficult to make a same frequency, but the time goes, eventually we have the same oscillation, but first frequency difference is very small. The EEG oscillation make a very fast entrainment. That's the basic idea. This is the study of our photobiomodulation. The above is the continuous stimulation, below is the frequency stimulation. Basic setting of the experiment is to compare the real-time EEG changes during the stimulation. So in this figure, you can see the photic LED stimulator using the same dose of our device. And then we stimulate in this red target area and then compare the baseline and during the stimulation. After the recovery, we can continuously monitor during the stimulation, before and during the stimulation and after. And we can see that the subject cannot identify which one is the real stimulation. So this is the sham stimulation. This is the photobiomodulation, continuous, in this case, continuous photobiomodulation. We can clearly see the change of this is the gamma, only gamma activity is significantly changing when we use the sham continuous stimulation. We can see the gamma activity increased in the stimulation area like this. So usually in other study shows the similar result. The continuous stimulation, only the beta and gamma activity increase in the stimulation area. So that's why continuous stimulation only activate the frequency oscillation in the faster frequency area, the beta 3 or gamma. So it is not useful for, we want to calm down a specific brain area. So continuous stimulation cannot work very well in that case. Only unidirectional, only increase of the frequency oscillation. But the polar biomodulation using the, for example, here, the frequency stimulation, this is the change of the easy rhythm when you use the sham stimulation, when you use the 10 Hz stimulation, when you use the 20 Hz stimulation, and Fourier stimulation. This is the change of the beta 2 band, for example. The sham stimulation, and then we compare sham and 10 Hz, sham and 20 Hz, sham and 40 Hz. When we only see the beta 2 band, the sham and 10 Hz stimulation cannot make any changes in the beta 2 band. And the Fourier stimulation cannot make the significant change in the beta 2 band. But we can see the 20 Hz stimulation can make the beta 2 band changes significantly in this area. But it is a little bit different compared to this one. The frequency stimulation area of the significant changes a little bit different. I'm not. I don't have a deep understanding of why this is a little bit changed, but we can see only the frequency. I think this is a kind of network effect. But this is the change we can see when we use the specific frequency, and that frequency band, we can see the change of the significant increase in that frequency. And this is the same we can try. We did try for the gamma band. This is the sham stimulation and 10 Hz stimulation, 20 Hz stimulation, and 40 Hz stimulation. And we can compare these two, sham and 10, sham and 20, sham and 40. In the gamma band, we can see the very clear change in the gamma band activity only in the 40 Hz stimulation. The 40 Hz stimulation make up gamma band changes, but 20 Hz stimulation cannot make the gamma band changes, and 10 Hz make a little gamma band changes. It's a kind of a little cross-related, I think, but it is not big one compared to the sham and Fourier stimulation in the gamma band activity changes. So I think this is the entrainment effect. And we have the two different devices. The first device is we use a little bit lower. We use the 10 milliampere, and this is a 20 milliampere. So optical power usually 2 times in the iSyncWave. iSyncWave gives the 20 milliwatt for each LED device. iSyncWave use the 10 milliwatt for each device. That's the difference in terms of polar biomodulation. And I will briefly review the previous clinical study in the polar biomodulation. The very well-known study is the NEST study. The NEST study is 1 to 3 different NEST study. The first study, they recruited the 120 patients, and they use they can see this kind of intervention effect. And this is the treatment during the rehabilitation. This is very acute phase stroke rehabilitation. Acute phase means just you can see within the 24 hours of stroke onset. we can see the clear decrease, this kind of stroke scale. In the active intervention, the stroke scale reduced rapidly compared to the control group. So this shows the very good intervention effect in the stroke rehabilitation acute phase. And the key result, we can see the significant decrease of the primary outcome is the NIHSS, and the secondary outcome measure is the modified Rankin scale, also decreased a lot. So, but there is no significant difference in the side effect. So they have the safe and the effective. They show the safe and effectiveness of the photobiomodulation, but the sample size is not big, so they need a bigger study. So that's why they designed the following study, NEST2. The NEST2 is the 660 patient, basically similar flow of the research protocol. And in this case, primary outcome measure is the modified Rankin scale. But you can see here that this is the post-hoc analysis. What actually they have the 36% efficacy in the treatment group and 30% efficacy in the sham group. They cannot achieve the statistical significance in that case. So they need to go through this kind of post-hoc analysis. They found some moderate case of moderate case of the stroke population. They combine these two subgroup, make significant changes. So moderate and moderately severe stroke group is respond very well, they found, using the post-hoc analysis. So that's why they need to go through another clinical study using this moderate to moderately severe stroke population to make a real significant in the large number of the population. That's why they did another study for that stroke scale group, moderate and moderately severe group. And this is the acute phase stroke rehabilitation. Actually, they used the methodology of they use the LED laser device, only one laser device, the one site 2-minute stimulation, and then the another site 2-minute stimulation, and then like this, then 20 location stimulation. It takes the 40 minutes for each people. So, and also the basic their idea is just one stimulation within the 42 hours. So within the 24 hours, so their stimulation is very limited, basically. So that's why finally they have this kind of efficacy data. You can see the all data is do not show the efficacy in the primary outcome measure here. Primary outcome is not significantly changed in the intervention group compared to the control group. So that's the clinical study stopped here because the large group study, they cannot find the efficacy in the large group study. I think the basic cause of the failure of their clinical study is actually they use they they use the same protocol, not personalized protocol, and they only use the one stimulation within the 24 hours after the after the after the stroke. So the limited stimulation and the no personalization make this kind of the failure of showing the efficacy, I think. That's why the after study, this study made by the Dr. Nazer in the Boston Healthcare Research. And Dr. Nazer is very famous in the TBI photobiomodulation. And also she did the stroke population, photobiomodulation for the stroke population. The participant is very small. In this case, only 6 cases. And all the stroke patients have the left hemisphere stroke. And this is not acute phase stroke rehabilitation after 2 and some people having the 8 years post stroke. And they Dr. Nazer used the 18 photobiomodulation session, the three times per week, and she used the 2 different frequency, and also, and she used a very individualized protocol, for example, compared to the NEST study. So that's the change of difference of the, there are many differences in comparing to the previous study, but and here is the basically outcome measure is the naming ability and also the functional brain imaging. So they want to find the efficacy in the improvement on naming ability and also in the associate change in the fMRI brain imaging analysis. Basic idea of this research is that they used different protocol A, B, C, D. The protocol A is the bilateral stimulation, like NEST study, and protocol B, the left hemisphere stimulation, because they usually have the language problem, usually having the left hemisphere region. So protocol B is only focused on the left hemisphere, and protocol C is the left hemisphere plus the 1 default mode network node, and protocol D, the 2 default mode network node. And this is the protocol is a little bit different, but the efficacy, we can see the summarize of the protocol in this table, and efficacy of the result is very different. You can see the protocol bilateral stimulation, they used they found no improvement in the naming ability. So that means the NEST study also used the bilateral, but NEST study is not at the not give the stimulus at the same time 1 by 1 and just one time 2-minute stimulus, very short. I think not enough stimulation in that case, and also in the no personalization, but it is very similar to the NEST study, just in terms of the location. All area is simulated in this case, and in the same way, and protocol B in the left only stimulation protocol showed a significant improvement, and the left hemisphere and the 1 default mode only moderate and poor improvement, but left hemisphere with 2 default mode is good naming improvement. So basic idea, concept of this clinical study, the different protocol give us the different improvement. I think we can speculate from this study, the protocol is very important. The personalization, specific target area selection is important thing for making a better outcome. That's the basic idea concept we can get from this biomodulation stroke rehabilitation study. And also they can see the this kind of improvement and functional brain connectivity increase is quietly associated. They can see only in the behavior changes. They also see in the behavior changes and the related objective measure changes. They use the functional brain connectivity. So that's very good research, I think. I also include another photobiomodulation study when combined with the language therapy. During the language therapy, they can easily combine the photobiomodulation. In this, we can easily combine. In this study, show the combined effect. This is very small one sample study, but we can see the therapy is the post therapy is the 5 months language therapy, but no improvement. After 5 months, they combine the photobiomodulation using the conventional speech therapy, speech language therapy, SLT. Then the significant improvement they can see. So this is the basic post photobiomodulation. They use the this kind of two-session approach in the photobiomodulation and the photobiomodulation and the speech therapy, 20 minutes. The 8-minute photobiomodulation making a kind of warming of the specific language hemisphere area, and then start the speech therapy. This is we can see this kind of methodology in the photobiomodulation and then neurofeedback. The real training makes some kind of warming. So using the neuromodulation, we can make the preparatory oscillation status for the real training, and then we can combine the neuromodulation after combine the real training, such as the speech training and also neurofeedback training, and sometimes we can combine the cognitive behavior therapy during the neuromodulation. That makes the big efficacy in the literature. This study shows the combining the photobiomodulation and the speech therapy make bigger changes. You can see only the speech therapy, there is no improvement, but after combining the photobiomodulation, the speech rate and increase this kind of lengthening of the speech with the complex grammar and intelligence increased, and clear improvement of articulation and comprehension and voice tone and intonation. That shows the clear change of the photobiomodulation when combined with this kind of intervention makes a bigger efficacy. So that's the concept we can get from the previous photobiomodulation clinical study. And we can use the specific protocol, personalized protocol, and also we can combine some kind of intervention. And this is a very exciting cases using our photobiomodulation in the stroke rehabilitation. The patient, this is the patient information. The 60-year-old male having the middle cerebral artery stroke 4 years ago, and basic symptom is the speech problem, and also he cannot recognize number and quiz guided PBM approach. And here is his CT scan. The left right is reversed in the CT scan. You can see in this area, the right area is a bigger region. That means left hemisphere is the bigger region during the stroke. So that's why he have the left hemisphere. Actually, CT scan is reversed. The right area is actually left hemisphere, he has a very big language problem after the stroke. So he cannot express this is the 4 years after the stroke, and then the basic his symptom, he cannot express only repeated word, and he had been speech therapy for 2 years before the intervention. His vocabulary is few word and did not recognize number. But after the intervention, 2 months intervention, he start construct the sentence and answer question. The vocabulary has improved and speak at the conversational level. Has all his neighbors finding very exciting, his amazing improvement, and he answered the question very detailed, and now he start to recognize number. So there's the very big changes. We need to see the QEEG changes during this exciting improvement. So we can go to the EEG finding first. The EEG is actually having the amplitude and frequency relation. The slow frequency usually having the larger amplitude, higher frequency usually having the smaller amplitude. We can see in the this T3 and C3, T5 and P3 having the bigger amplitude compared to other channel, and the F3 is a little bit bigger. So this F3, T3, C3, T5, P3, all the left hemisphere area. So that means this area a little bit large amplitude. That means a slower frequency. In this case, this is the slow theta activity. Sometimes a little bit slow alpha, but theta and alpha increased a lot in this left hemisphere area at the baseline, and we can see in the QEEG this kind of fibers excess in the Broca area and also in the left hemisphere area and also in this area. This is the P3 area is related to the mass processing area. So we can see the very big excessive. The purple is usually G-score 3, red is 2, the yellow is 1. So you can clearly see the change of his EEG compared to the normative database, this left hemisphere region area. And in the QEEG summary, we can see the very underactive in the front and also in the left. You can see here, this left hemisphere is very underactive. And this is the baseline. This is the protocol. The first protocol is the 10 Hz left hemisphere stimulation and the 12 Hz right hemisphere stimulation. The 5 and 5 minutes is total is 10 minutes. And first photobiomodulated PBM protocol is 3 sessions per week, and left and right a little bit different stimulation because left is too slow. We can see just 10 Hz gently activate the left hemisphere and also stimulate right hemisphere using another frequency. This is the first month, and then the second month this is not my case, my client cases. Second month, they use the global 20 Hz stimulation, and the stimulation is increased in 15 minutes, and then they step by step increase the dose of the PBM stimulus. Finally, they have the 20 Hz stimulation, 20 minute stimulation. Basically 3 sessions per week. After this 2 months intervention, they show the very promising result, and they can continue the 20 Hz 10 minutes and 13 Hz 10 minutes from the third month. and eventually go to the 13 Hertz 20 minute, and the session is the 4 to 6 session per week. Every day he get the PVM a little bit past the frequency, and post months he used the 13 Hertz 20 minute and then 14 Hertz stimulation. The 14 Hertz except this visual area, and finally they use the frontal 15 Hertz stimulation per minute. They add the 4 minute frontal stimulation. Step-by-step increase of the frequency from the 10 Hertz to the 14 Hertz, 15 Hertz. This is the baseline, and we can see in the 2 months follow-up data here, we can still see in the T3 and C3, T5 and P3, this is the baseline activity, and this is the 2 months follow-up. We can see the F3 a little slow wave is a little bit decreased, and also T3 is a little bit decreased. The C3 is substantially decreased. In T5, the slow wave is decreased a little bit. P3 has decreased a little bit. This is we can see in the clean data, and also this kind of slow wave changes in the QEEG. We can see the fibers a little bit diffused here, but 6 Hertz substantially decreased, and 7 Hertz also decreased, especially in this C3 and P3 area, and 8 Hertz is the similar. And we can see the increase of the 10 Hertz because we use the 10 Hertz stimulation in the left. So we can see the 10 Hertz increase like this after the 2 months follow-up. And this is the change of the QEEG in the baseline and the 2 months follow-up. The slow frequency decreased 6, 7, 8 Hertz, and also increase of the 10 Hertz in the left. We can see this kind of changes in the QEEG, and at the same time we can see the improvement in his language. And even before the PVM, they got the 2 years. The patient has the 2 years speech rehabilitation, but the speech therapy is not showing the improvement, but the photobiomodulation make bigger changes. And this is the spectra we can see here. The EEG spectra, you can see this kind of 2 separate alpha peak. The slow alpha, usually coming from the ischemia biomarker, slow alpha. This is the 8 Hertz alpha peak activity. We can call the J. Gunkelman called this the slow edge of alpha is the ischemia biomarker. Ischemia is coming from the various situation. And in the aging population, we can easily see this kind of 2 alpha peak and also slow edge of alpha. And the post-COVID inflammation make this kind of slow edge of alpha. This is the another ischemia condition coming from the inflammation, and the TBI population also having this kind of slow edge of alpha in the lesion area. TBI, post-COVID, and stroke, and also aging population, and you can see this kind of slow edge of alpha very easily. So this slow edge of alpha here, T5, and we still having the similar spectra, but the high frequency, the 10 Hertz alpha is increased, as you can see in the T5 before and after, and the P3, the slow edge of alpha, the 8 frequency decrease, the 10 Hertz increase, and the C3, the alpha activity in C3 is not good and decreased a lot, and also in the T3, we can see the 10 Hertz activity. The first, we only have the 8 hertz slow edge of alpha, and now 10 hertz is increased like this. And F3, F7, we can also see the slow edge of alpha still remained, but the 10 hertz increase. This kind of 10 hertz increase make bigger changes in the in his speech ability. So 10 hertz stimulation in the left hemisphere and 12 hertz stimulation in the right hemisphere, and the combined 12 hertz stimulation, that was the protocol. That kind of protocol make effective changes in this case. And this is the pre and post, our summary report. We can see basically the red area is underactive area, decreased a lot, and his symptom is improved. And also you can see the increase of the percentile value. This is the source level theta beta ratio. The old area is a little bit increased. Percentile is increased. That means theta is reduced, beta is increased in the old area. And I would like to show you this case in the real portal. In the portal, we can see also these changes. We don't have enough time, but I'll give you basically in this case. I want to show you eyes open. This is the post, and this is the baseline. This is the same data we saw in the presentation, but I want to give you this kind of component information. We can design the photobiomodulation just using this kind of component, because the first we have the basically 19 component coming from this 19 sensor level oscillation. The 19 component coming from the 19 time series is usually arranged in the order of the power. Only using the first abnormal component, we can design the photobiomodulation, neuromodulation. And the first component is the biggest component. If the first component is abnormal, we can target that the first abnormal component, most influential neural component, we can target for the neuromodulation and also photobiomodulation here. The first neural component, we can see this kind of slow edge of alpha in this left hemisphere area, especially we can see the post-central area, maybe the C3 and P3 area. Here is the language problem is coming from this kind of abnormal pattern. So we can target this area showing this kind of slow edge of alpha, ischemia biomarker. We can gently activate this area using the photobiomodulation. Then we can use the 10 Hz or 11 Hz, 12 Hz step by step in this region area. And then we can also see the very slow alpha activity in the T5 area. And also we can see the T3 slow alpha area. So, and also frontal, very slow theta, 5 Hz rhythm here. In the EEG, the basically normal rhythm is the decreasing pattern, sliding pattern of the frequency amplitude relation in the spectra. So except alpha peak activity, another except alpha peak activity and sliding pattern, except this, all the abnormal. So we can easily see the abnormal, easily find the abnormal component. This component is abnormal because the slow edge of alpha, and another alpha peak in except this visual area, PZ0102 is the problem. So we can target this one we can target this one, and also we can target this area, and also this area is also could be the target in this stroke patient having the many abnormal neural oscillation. And here it is the decreasing pattern of the spectra, but we have the very wide beta peak here. This is the usually muscle activity and very localized, but we still having this kind of diffused pattern is the neural activity, but this activity, this localized activity is the muscle activity. And also we have this kind of slow wave activity combined with a little bit beta activity. And this is a typical eye blink. And this is the normal alpha rhythm. Usually we can see in the back of the head. So the post neural component we found is the left hemisphere problem, number 1, number 2, number 3, number 4. All left area can be a target for the neuromodulation. That's why we can choose the left hemisphere stimulation first with the 10 Hz. This is the follow-up data. You can see in the follow-up data, we can see the slow wave is decreased a lot. And we can see in the same pattern in the component. The first component is you can see the temporal slow wave activity in theta and alpha. And you can see this is the P3 alpha activity. This is the not a good alpha location. But and also we can still see this kind of slow activity in the T5, and this is the yes, we can also see the little bit slow frequency in this left-sided area, and also this is the healthy real alpha activity, and you can see the little bit slow edge of alpha is combined. The only comparing of the component are very difficult to find the extent of abnormality, but the component is very useful to make a design of the protocol. First, combining first 3 abnormal component, we can easily target. In this case, the left hemisphere we can target. So that's the protocol generation using the component information. So before and after changes, we can use this kind of normative comparison like this, and normative comparison like this. I already showed this. This is the pre, and this is the post, and here is the artifact a little bit remained, and the first component having this kind of pulse artifact, but also having this kind of theta activity. Sometimes it is very difficult to differentiate this. This is a very important activity, neural activity. This is combined pulse activity. If we reject this component, then we also lose this slow wave that sometimes we cannot detect very well in this temporal in this slow activity. But important thing is the theta frequency. We can see the good improvement. Using the normative comparison, we can find the extent of abnormality. But using the component, we can easily find the abnormal source location. We can design the pulse biomodulation protocol only using this kind of component. The component is very useful window for designing of the neuromodulation. I would like to have some kind of discussion about the quiz-guided pulse biomodulation in our stroke rehabilitation cases.